Keynote 426, just a little bit of background regarding the design of the study, enrolled patients who had treatment naive, clear cell RCC, no prior systemic therapy, patients had measurable disease, patients were randomized 1-to-1 to receive pembro-axi versus sunitinib. The trial enrolled 861 patients with a dual primary endpoint of OS and PFS in the intent to treat patient population. It's interesting to see the updated data, and it's interesting to see the updated data in the context of the updated Checkmate 214 data. While we certainly can't compare these trials head to head, they're different trials, they were done at different times, enrolled different patient populations. We know Keynote accrued most of the patients not in the US, accrued a larger percentage of patients who had favorable risk disease. With Checkmate 214, it included more intermediate and poor risk patients, and the primary endpoint was really defined around those intermediate and poor risk patients. But what we seem to see over time, so the follow-up around 23 months with Keynote 426, is we actually see that the hazard ratio is kind of goes from 0.53 for the intent to treat population to 0.68 over time. So the data, not to say it doesn't look as good, but it's over time, the big question is going to be what are the durability of these responses that we see with IO-VEGF versus durability of responses that we see with IO-IO. So with Checkmate 214, updated data at 30 months, that hazard ratio is at 0.71. Checkmate 214, again, updated data at 42 months that were presented at GU ASCO, hazard ratio 0.72. So it's just holding steady. Those curves are holding steady. The PFS curves, there's kind of a tail on the curve, that there seem to be people who have long, durable disease control, that are benefiting from therapy, and whether that is going to hold out for the VEGF-IO combo, I think remains to be seen. I think the data just over time, doesn't look as good. And so I think we have to really, the big questions with IO are what are the durability of responses? What does a complete response mean? What does a deep PR mean? Can we cure these patients with IO-based therapies? And so, we'll have to see what happens with longer follow-up. The other interesting piece is, what happened to the favorable risk patients. So with the 7-month median follow-up at the first analysis, the hazard ratio for OS for the favorable risk patients was 0.64. And, there's a lot of discussion around, there with Nivo-Ipi, there seemed to be a preferential benefit to Sutent for those patients compared to IO-IO for the favorable risk patients. But now with updated follow-up at 23 months, the hazard ratio is 1.06, went from 0.64 to 1.06. So, it tells me no difference between Sutent versus pembro-axi, and pembro-axi is a more toxic regimen. So I think, I think time is going to tell what happens to, the data, and really what happens to that PFS curve. But I think it's pembro-axi is certainly a very active regimen. The PD rate is very low with pembro-axi, and it certainly has a role in the frontline space. We will have to see over time the durability of the response and durability of benefit.